learn on cytotoxic or hazardous drug and what to do, how they're labeled. Does anybody remember taking that you learned?
What if you didn't get it?
You can assign yourself.
Is it under
It's called hazardous drug.
Right, yeah, I'll do that.
If you, or you know, you can ask me, like, you shoot me, you know,
I'll do it.
whatever. But anybody can sign up for that. It's called safe handling of hazardous drug. With that, it talks about the new hazardous drug door signs that's replacing our cytotoxic signs. We have those on order, and we have those in-house now. Other things that are in-house that will increase our usage of is the cytotoxic gowns and cytotoxic bins. So our car has been increased for those, so we can use those when this rolls out starting June 1st. In addition to that, there's a hazardous drug resource binder at Central Pod. I only need one binder for Central, but if there needs one at each pod, I can absolutely do that. And this just talks about why the change, what PPE you need to use, what class drugs are, which drugs are which class, so class 1, 2, or 3, and what kind of PPE you need for them. So here's a list of the drugs. Here is your hazardous drug PPE, depending on what kind of route your medication is it IV, is it PO, what to do, where to dispose of the wrapper. Talks about double gloving, even though our chemo, or even though our gloves are all chemo, like, okayed, still double gloving when you're giving that medication and then taking off that first set of gloves to do like your documentation or whatever, just so your hands don't get anywhere near the hazardous drug. If it, you know, could be on the computer or, you know, wherever. So resource binder there, and I think Ariel and Brandy and Danielle are going to do a little bit more teaching and education, so look out for maybe a survey or an audit regarding what our practice is now for hazardous drug or cytotoxic. So anyways, more to come on that. Any questions about hazardous drug? The other thing is, there's a new video that's uploaded to Surgical Specialties site. So there is a link on SharePoint that is to our like Surgical Specialties video platform. You can find all kinds of videos on there. The one I just uploaded was when Sarah Funk was talking about the different kinds of surgical diets. So that's on there. Another update for downtime resources. We almost had a scary day. But luckily we didn't have to use anything. So downtime, in case there is a downtime, we all should be familiar with our downtime books, which is ACA. There's 2 of these books, one at Central and one at the PSC desk. In here, just a quick FYI, this tells you, how to get onto the BCA computer, how to run reports. But I also created this little tab called RN Resource. This is for you guys. Hopefully it'll help next time when we're doing downtime, how to write orders, or maybe how to instruct the docs on how to write orders, or like paper orders. Okay, what to do, what to fill out, what the kind of the process is. Other new things, this used to be the old lab form. For all your labs, you just check off whatever lab, hit mark stat or not. This is old, so that's going away. You'll now see one of 2 different lab forms. One is stat, which is this one, which is kind of confusing, and it says critical for care, meaning that this is stat, and it says stat downtime lab request. So it's a little confusing because it says critical for care. I automatically think, oh, that's critical care. It's not. This is our stat request form. And then the other form is exactly the same. This is our routine lab. So these forms, again, are in the BCA binder up at the PSC desk if you need these. So that's new. Other references in here are medication orders. There is a cover sheet that goes along with medications. It's kind of small, but you guys can see with any kind of medication order, you would fax or scan this cover sheet down to pharmacy, depending if the fax machine is working, or to that, right? Then also, just a quick reference on how to do paper charting. Yes, our paper charts do not look anything like Epic. The hospital is currently working on it to maybe mirror Epic and what we actually chart. But for now, this is what we have, and this is kind of, just an example or a sample of how to chart, what it looks like when already filled out. Same with your assessment piece. That goes on to the second page, and then the good old days when you wrote narratives of your patient in your day. So little rules or little tidbits nurses for us to follow when you're doing those. Yeah. So again, this is that central pod. There's also one in the PSD desk, and it's a little tab that says RN resource. Okay, so that is there for you, or if you need to talk to the docs through writing paper orders. In addition to the binders, if we're not able to get onto Epic, but we still have like computer access, there is, I'm gonna use my pointer. There is a downtime in the shared drive, right? Not SharePoint, shared drive, the folder. There's a downtime folder. In this folder are all those documents, the back charting, how to do back charting, all those kinds of things. So it's just electronic forms of whatever's in there. So that's there if you need. Next, surgical site infection. This is one part of two parts that'll be rolling out soon. The first part, to help our surgical site infections go down, we are starting to implement a pre-op shower. So if these are for patients who we know are going to surgery, they have a scheduled surgery, 3 o'clock, they're gonna go down. Okay, that patient needs to bathe with Hibiclens, which is now stocked in our central. Or if they can't get into the shower, doing a CHG wipe bath. Okay, you might need a couple of packets for those. But it's super important to make sure we do those baths, not only the baths, to change the patient's gown, new gown before surgery, and bed change before surgery. So those 3 things, and then document, obviously, that in the Epic. Where to document the shower, there is, who knows about this OR pre-op checklist? Great, Morgan, awesome. So this has kind of fallen off, I would say, in the past couple years, that anytime our patients are going to OR, which is quite frequently, that we have this OR checklist. So we, as the nurses sending our patients off to the OR, should tap this little guy in here, and it says OR pre-op checklist. So, did you take all the jewelry off your patient? Did they go pee before you sent them down? Did they do their bath before they went down? So you should be tabbing, wrenching that in and charting under, and that's where you would chart the bath. Okay. So use that checklist. Helps remind you of different things you may not have known that we were supposed to check off before we send our patients off to OR. Side note, I just kind of talked about that. We should be using it. Okay, great. So what should we be using for our patients? It needs to be like CHG, chlorhexidine, antimicrobial, which none of these are, but these are. Thank you, Alexandra. So again, that's stocked in central pods, CHG wipes, we all know what those are, but these are not acceptable uses for our pre-op bathing. PACU handoff. This is a tip sheet regarding what to expect from the PACU when they call you for handoff. Couple of things I just highlighted here is if you have a patient getting assigned to you, make sure you're looking the patient up, which we already do. There is a PACU transfer summary in Epic that you can quick review. It does MAR review, does a comprehensive assessment. Also, PACU RN will send a patient up after 15 minutes if they have not heard back from the RN. So if you have any additional questions, make sure to call them back before they send them. or if you're like, ooh, his files don't look right, call them back, or else they're gonna be sending them. Any issues regarding handoff, please write a PSN or a SI for care coordination / communication is the keyword. They're tracking this and just to see, like, do we have any problems with handoff? If there are, we need to know about it so we can fix it. Okay. Speaking of handoff, dialysis. Again, things, we had a SI report not too long ago where the nurse didn't get report from dialysis, and they just came up on the unit. So there should be a handoff report over the phone, what you should give to the dialysis nurse, and what you should kind of know before sending your patients or receiving them. They can't really hold patients down there because it's such a small space. So when they're ready, they kind of got to get out. Unless they're unstable, then we'll have that conversation. But they really can't just hold off on sending their patients back up to us. But again, what you can expect from the dialysis nurse, they should do a handoff, including any status changes, instability, their plan of care, their treatment. Also, a little note about medications. If they're due a medication, say even like something simple like oxycodone or whatever, maybe that was a bad example. If they need an antibiotic, let's say, in dialysis at the time that they're gonna go, you can send that with the patient. Their Pyxis is super small, so they don't have access to a lot of the meds that we do, so they will be happy to give it. They said, you just need to give it to them. So that's, or tube it down or whatever. If it's narcotic, you can probably do a secure tube and give them that quickly. CNA scope of practice has changed. So effective on the 30th, all new hire CNAs will be now trained to do bladder scan, DC IV, and a DC Foley. And all new hires, or no, all current CNAs and ACPs have also been trained on this. So what you guys might be seeing now already is being asked to sign off on those things. Similar to how we do to ACPs. Hey, I need 3 checkoffs so I can do this blood draw. Can you watch me 3 times? Sign me off, and then I can do it. So same thing with the CNAs, with bladder scan, DCIB, and DC Foley. So you'll be asked to sign those off 3 times before they can do that task independently. Side note regarding signing off ACPs and CNAs, this is their first time doing it. There's a reason why we have nurses observing to sign these guys off. So make sure that you're giving them tips, giving them feedback, that was right, oh, you might want to do it like this next time, or just give them real time in the moment feedback if they're doing that whatever task correctly. Okay, so make sure you're watching them if you're the one signing off on them. Any questions about that? Issues that we've noticed at all? Committees. How do I join a committee? There is a committee tab. It says, or on SharePoint, that you can go into, and it'll tell you how to join a committee, where to go, what committees are open. So if you have any questions, or hey, I'm thinking of joining a committee, go to SharePoint, to our committees page, and it'll kind of walk you through. There's a bunch of documents on there to look at if you're interested in a committee to see which ones are open. This is just mostly just an FYI about leadership and growth, personal growth and development. There's a bunch of classes on the organizational development webpage. Just search it. And these are like a bunch of classes you can take. Like it looks good on your eval. It helps you, you know, improve professionally. Like mentoring, how to get feedback. So really good classes that are free that any of us can sign up for. So I would tap into that if you're interested. There's some good classes. Annual competency are due June 30th. So thank you for those of you who have turned those into me already. Couple of things to know. Make sure that this cover sheet, you attach that with all of your supporting documents. So that's important. all of your CEs and chart audits go to your charge buddy for your evaluation, your annual evaluation. Doesn't go a part of your competency. That was more of a just the FYI, what to expect from that you should be giving to your chargers for your eval. So all of these things, which is dysrhythmia, CLABC, purposeful rounding, annual skills lab, glucometer competency, should be turned in to me if you haven't already with a cover sheet. CEs and chart audits will go to your chargers. Any questions? That was kind of a lot. Thanks, guys.
Thanks, Shan.
Thanks, Connie.
I want to apologize in advance. This room is booked at 12 o'clock, so we're going to fly through the next couple slides. Okay. I may have Angie go first, just because hers is really meaningful, and there's a lot of people here, so it'd be good for everybody to hear it.
Well, first of all, do we have any new staff members in the room for the first time? Jenna? And guess what? It's Jenna's birthday today. Happy birthday to you. Also, I have a recognition for Connie. I was just notified that Connie hit 15 years of service at UC Health. And I know the hospital gave you a gift too. So.
This leather Ralph Lauren bag.
How awesome. So thank you, Connie.
Praise to stay.
For hanging in there for that 15 years.
Thanks.
Means a lot. I got just a couple quick updates, and then we're going to talk about creating our vision for our floor. Our annual performance evals, believe it or not, it's time to do those again. They are going to open sometime in July. We'll have until like the first part of September to get those done. Morgan is going to do Michelle's group, leadership group, and the permanent charges will do their own leadership group on our matrix there. And Jen Bings is actually coming back to work a little bit early from maternity leave, so she'll be back end of June, early July, and she's going to do your performance evaluations, and she's going to seek our support and input as well. So I think we're set for performance evaluations. All the permanent charge nurses will be here. Kristen won't be quite on a maternity leave yet, so I feel like we're going to get them all done, completed. Last year was a very smooth process, and hopefully we can just repeat that this year. And we actually, like, in a week and a half, we actually have our first orientation about the performance evaluations, more information. And I understand they're even easier to do this year, so let's just hope for that, and we can get through these very, very swiftly. There was a Psych Summit about a week and a half ago with some of the nursing executives, administrators, some of the nurse managers attended as well. And we honestly know how rough it is on the floor with some of our patients who are very difficult patients, very difficult family members. It's happening on every single unit. We don't have a lot of resources to reach out to, and like, how do we handle this situation? And so the Psych Summit was about trying to get more resources in the hospital, especially for the inpatient areas, to help. To be able to call somebody, to page somebody when someone is escalating or there's a really difficult family situation or whatever's going on. So I don't have a timeline yet, but to let you know, the hospital is taking this very, very seriously. And what they're looking at, I don't know quite the numbers yet, but they're looking at hiring NPs and PAs that specialize only in these psych patients. So we would have a resource, like we have acute pain service, we would have a pager and a resource that would float between all the units and be able to have somebody to come and help us de-escalate a situation, or, you know, we have a patient constantly refusing treatment, that they could work with that patient and they'd work with the medical team too. Does that sound like a great idea? I mean, I heard that and I was like, oh my God, I have to share that. I don't have specific details, but I know they're looking up to like having 5 come in, so that's good, that's really good. It's just gonna take time, it's not gonna happen overnight, and you guys probably know that already. The other thing, I'm gonna go quickly, because I know that we've got more speakers to go, and very little time, is I want to talk a little bit about establishing a unit vision, mission, and some core values. In the past, we've established these a unit mission with each unit, and what that looks like is in the past, and it's tradition that usually like HR gets involved with the leadership team, the permanent charge nurses, educator, manager, associate, and we have an all-day retreat. We talk about core values, what's meaningful to us in our work. The leadership team establishes the unit vision, establishes the core values, takes it back to the team for approval, and everyone says, yeah, this is what we like, this is what we want to do, this is what we're here for. Well, I want to do it differently this year. I want it to come from you guys. I want you guys to help create our unit vision. We've been here now, this month we've been here for a whole year, and we've got 60 new staff members, and we've got about 28 to 30 of our staff members that came with us from 6 East. And I think it's a great time for all of us to have input about what does our workplace look like? What is our meaning? What is our purpose in the hospital? Up here we've got, oh, can you go back? I'm sorry. This is our UC Health mission, vision, values. This is our system one. I hope this is not new to anybody. I hope you got it in orientation and you see it flashed on the hub once in a while. Sorry. So when general surgery was on the 9th floor in pulmonary, we were together and I managed both units. The charge nurse leadership team, educator, we came up with our core values of integrity, competence, professionalism, helping others, communication. We shared it with the team, it was approved, and that's what was most important to us in our work environment. Our vision statement, the 9th floor staff are inspired to exceed patient expectations through professionalism, integrity, and quality care. We are a unified and committed specialized care team who strive for excellence always. And we just developed that. We did all kinds of worksheets and stuff like that, but that's what was important to us. So a couple of years ago, gosh, it's been 3 years. 3 years ago, general surgery and transplant were over on 6 East. We did the same thing. We worked with HR, we came up with our core values, which you can see are a little bit different than what the pulmonary and surgery unit was. And we developed a vision statement. We are a specialized surgical and transplant care team committed to improving the lives of patients and families through compassionate, high-quality care in a community that values integrity, teamwork, and lifelong learning. Well, I'm sure that as we drill down and we develop our own vision statement, we're going to have probably different core values. We're going to want to do a different vision statement, but it will give us some meaning to what we're doing here on the floor. And once we get that developed, we're going to go ahead and we're going to put our new vision values on a plaque to display on our unit so everyone can see what our vision is for the unit. So how this is going to work is that I am going to send out, myself or Rochelle will send out a little survey monkey probably within the next week and asking you about, a lot of them are self-reflections. And a couple of the questions I'll just share with you. It's very simple, very easy. It's what puts you in a bad mood at work? What puts you in a good mood at work? So trying to do that deeper dive of what's most important to you. And there's a couple more questions too, very simple. It's Survey Monkey because we don't care, we're not going to tie any names to the answers or anything. We want you to be very honest, give good feedback, and we're going to look for trends and track trends. And in our June staff meeting, we're going to do it on the SharePoint site. And so I'm going to ask you some questions to share. What are your work values? I'll put up a list, a whole PowerPoint slide of what common values are: trust, integrity, teamwork, and stuff like that. You can look and review those. You don't have to choose those. You can choose whatever you want, whatever comes to your heart. And tell us, what do you value here at work? And then how do you find meaning in your work? So it's not just a job. It's just not something you're coming in and you kind of dread coming to work sometimes, right? How do we create the best place to work? After that, I'm gonna look through the answers, have the leadership team, share it with the leadership team. We want to share it with SERV committee, share it with our charge nurse group, and then form a working group. And in the working group will be ACPs, CNAs, RNs, leaders on the floor. We're all going to work together. We might do this all online. We might actually meet for an hour or two once and everyone will be paid who wants to volunteer for it. So this is gonna be voluntary, but we're gonna work hard and we're gonna put all these themes and ideas together and try to come up with a vision statement and share it with staff, get approval from everybody. And so how many of you feel like this is something that's very doable, and something important? Yeah, are you just raising your hand because I did? Okay, I'm gonna stop there because I know we're running out of time and I want Kelsey and Morgan to be able to go too. But, you know, hopefully you'll look at this very exciting. This is gonna uncover some of the problem areas that we're having, maybe. And this will help us really strengthen our, you know, what's working well on the unit too. So more to come, more in the Survey Monkey. It's gonna be very short, please take it. And then more in the June staff meeting, okay?
The video forever.
Alright, no pass down. So our nurse call audits for April, we're at 84% for RNs, so we have a little ways to go. If you haven't logged in at 100%, you got an email from me. You'll continue getting an email from me every month until we all reach 100%. But I do have to say that the last few shifts I've worked, everyone's been logged in, so it's been really great where we're doing it. My HCAP scores for patient responsiveness have been in the 40s to 50s. But the last one I got a couple weeks ago, we were at 82, which is the highest I've seen, so that's also really great. If you're precepting and you have a phone, please ensure that you're logging into Nurse Call as well so that you can sign in to that third slot so that if your preceptee isn't with you and can't get to the phone, that way you have a chance to answer it as well. And then keep writing phone numbers on the whiteboards, not only writing them on there, but educating our patients on why we are writing them on there. If your pump's beeping, if you need pain meds, that way they're not calling the CNA who's just calling you. And then thank you for doing all of this and helping me and helping each other and helping our patients. Like you put this.
Maybe.
Lauren posted yellow signs all over the unit for me, just as a reminder for you guys. And then for RNs, if you're signing into the second spot, that's great, but please sign into the fourth slot in Nurse Call as well. That way you have a second chance to answer that call light. If you're on the phone, you accidentally hit end for a fall alarm, something that was there previously, and then you don't have a chance to get to the call button again. So fourth slots as well. And then RNs and CNAs at 6 o'clock in the morning and 6 o'clock at night, try to round on your patients. You're passing your 6 o'clock meds, you're just seeing what they need before huddle. That way, they're not calling during huddle, you can tell them, hey, at 7 we shift change, I'm gonna bring you the night nurse with so-and-so. And then, you know, we can try to decrease the amount of callers that are going off at huddle and while we're giving a report, because I know that that's like a really busy time. And so if we can try to do this, I think it will decrease what's going on during shift change, let everybody kind of get settled into their shift. So the also at 6, this is coming from Serve, we want to do like a cleanup. We had like the 10-minute before huddle, clean up your computer, wipe down your station, but we want it to be like you round, you clean up your area, that way at 7 we're ready to go, because I think the cleanup's kind of fallen off. Nobody's really doing it anymore. So just try to clean up the pod that you were sitting in, throw away any trash, and then round on your patients and be ready for huddle. So that gives you like an hour window to keep our unit tidy, okay? Where's the slides on? Oh. Alright, committee compliance. So annual evaluations are coming up. I think that's the 6th person who said that. So committee compliance, there will be a form, it's posted on SharePoint under the committee section. So if you want to join a committee, there's instructions on how. If you're already on a committee, this committee compliance sheet is on there as well. So just like your CEs, you'll write down the month, the committee you're on, and how you updated the unit. Then you'll turn that into your charge buddy with your CE log at the end of the year. We had a drastic increase in people joining committees when the tier system for scheduling rolled out. So it's just a way to make sure that if you're on a committee, you're going, you're educating the unit, just to keep everyone accountable. So you'll also need it quarterly, the form that gets turned into JRF to update the tiers. You'll need to make sure you show that to your charge buddy when they sign that form that says, yes, I'm going, yes, I'm updating. That way JRF and the SERV committee know that we're all doing this. So this is what it looks like. It's posted on SharePoint. There's like 30 copies in my mailbox in the break room. If you just want to grab one, you can take it. And then just fill it out and then have that with your CE log when you go to your annual evaluation. I think that's it. The other thing is if you're on a committee on SharePoint, there's a new form. So if you're joining a committee or if you're already on one at annual evaluations this year, you're going to sign this form. The form is just the expectations that our unit has if you're on a committee. So there was a really old one that was posted somewhere that no one was using, so we updated it. And it's just posted there as well. And it's on there just so that you know what expectations we have as a unit for your committee. And you know, that way at the end of the day there's no surprises. So everything's under there. SharePoint will load. And then just turn those in at annual evaluations too. We'll just roll it out all at once this year. That way you're not like hunting your charge buddy down and they're overwhelmed. But that's the list. I don't know what the other sheet is, but it's up. It will be there. Questions?
One of the big things I really want to hit on is the residents have a protected time. So they have mandatory classes that they have to be at on Monday, Tuesday, Thursday, and Friday. And usually the protected times are from 6 to 7:45. So during these times, it's really important that you guys call with only emergent issues. Like if somebody is a med call, you know, you have a significant change. This is not a time when you guys call for, you know, cleaning up the charts or collace or pain medicine to be rescheduled, okay? These are all things that can wait for them to come back at 8 o'clock, 7:45 in the morning. Is that cool? Right? We literally have 2 minutes because this room's double booked, Rob. So I'm gonna hand it over to you really quick. So this is Rob Montgomery. He is the CNS for APS. And he's here to talk about, we had an issue with an epidural a couple weeks ago where the order was the epidural was discontinued, and the bag of medicine was unspiked from the epidural that went into the patient's back and left hanging. And Rob's gonna kind of walk through how we could have handled that situation just a little bit differently.
Yeah, so I guess it got written up as an SI because the nurse unspiked the bag and left the spike hanging in the pump and connected to the tubing connected to the patient, connected to the catheter. So a bit odd because they didn't want to leave the bag of medicine in the box for some reason. But it was for an extended period. It was one of those situations where the epidural was stopped at the beginning of the day, and it was a test to see if the person was going to fly off the epidural medicine. They eventually did, but it really wasn't determined until later in the evening. And our team just said, we'll be up tomorrow to take it out. So just leave it there, like we've done before. But the nurse decided that they didn't like the bag hanging there, so they took the bag off. If you decide you don't like the bag hanging there, there are ways to get rid of the bag and the tubing appropriately, but that was not done. So critical thinking skills. Epidural lines it's a line with a little lure lock connection on it. So you do have to be careful because it can be mistaken for an IV connection, right? You could walk up to it, put a buff cap on it, you could put a syringe on it, which you don't want to do because the epidural catheter, when they put it in and it's a unattached end, and then they use the alligator clamp connector, right? Up and down, and then they just slide it in after they place it, and pinch down, and they're done. They take the little yellow cap off of it, and they inject medicine, put the little yellow cap back on. When the patient comes out of the recovery room, that's where the recovery room or the ICU nurse connects it to the tubing. You guys have done that before yourselves. It's Lorelei, sterile technique. That's all you have to remember. It's not complicated. I'm gonna pass this around just so you guys can play around with it. Take it apart, put it back together, squeeze some fluid through it. You're gonna see these centimeter markings, blue markings on the end, and then there's a little bit of, see those three holes coming out there? You can squeeze some water through it, some sterile saline, see what that looks like. So dead end blue connector come in these little packages, right? If there's a reason to disconnect it, that's the way to do it. I think I have another one in here. I did. Here it is. All you're going to do is, thank you, is just disconnect it from the tubing, put the little blue cap on, tape it up on their shoulder. Never put an IV buff cap on it, never put anything on that you can inject through. If you want to tape it up and say do not use, that's fine. The catheter can sit in the person for up to 24 hours or longer, and we've actually restarted them after that period of time. It's not in a vascular space, it's in an interstitial space. They potentially could become clogged and not work, but that's unusual. If you can never inject through it or the pump alarms, it's usually some problem in the system. The last thing is it's usually a kink on the catheter, kink of the catheter inside the patient, which you can't clear unless you pull the catheter back. Questions? Another thing that it said in the SI is the nurse didn't wanted to get rid of something about the pump was continuing to beep for hours. Well, if the pump is stopped, turn it off and turn it back on. I turn them off all the time because the beeping is ridiculous, right? If it's stopped for a period of time, if it's going to be stopped for more, I don't know, you guys use your judgment. I mean, if it was me at the bedside, if I was stopping that thing for more than half an hour, I would just turn the pump off because there's no sense in having an alarm and having to acknowledge it again and again and again, unless it's a temporary stop. Questions?
So what happened again?
So the nurse pulled the bag off the spike, left the spike in the pump, open to air, connected to tubing, connected to the
With no
catheter,
bag.
connected with no bag,
Oh.
because they wanted to get rid of the bag.
Oh.
Right? Is that what I read?
Mhm.
Okay.
Okay.
Yeah. So, all right. That's it.